Thanks again. I'll get to my job. So by now we have treated 155 adenomyosis. This is the comparatively older data when I sent this abstract to FUS Foundation. Not supported by any financial studies, and this is a good hospital. We are based on the ground floor, and the entire department on the ground floor. We have the easy access. Our OPD, which we run, which I told you, is also on the ground floor, so probably it's easily accessible to most of the patients who walk in. The purpose of this study was to assess the efficacy of the MRgFUS in treating adenomyosis by evaluation of non-perfused volume and symptom severity score, SSS. 94 Indian women with 115 significant symptomatic adenomyosis, whose SSS score was more than 10 to 1, were selected after approval from the ethics committee. The inclusion criteria included that all SSS score was more than 21, and adenomyosis with definable treatable area, that is area of more than 2 centimeters in length along the long axis of the beam path without the overlap of the uterine serosal surface. Those are the 2 criteria which you stick to decide and include the patient for the treatment for the adenomyosis. Exclusion criteria included the adenomyosis with SSS score of less than 21, area of adenomyosis less than definable the treatable area, and then usual contraindications for MR studies. The symptom severity score again ranged from questions for those 8 parameters, from heavy bleeding down to the fatigue, and asking ranging from 1 to 5, and score ranges for 1 to 40, and the non-perfused volume was calculated the similar way as we did for the uterine fibroid. All patients were followed up at the end of 6 months. Post-contrast MR pelvis scan was obtained. SSS and NPV was calculated in all these patients. Examples: the pre-treatment heterogeneously enhancing adenomyosis, and you can see immediate post-treatment, there is a large area of NPV, and 3 months and 6 months follow-up shows a progressive decrease both in the size of the adenomyosis and the non-perfused volume. In this case, at the end of the first treatment, we can see the area of the NPV, which probably many of people might think that it is enough because it's almost crossing 50%. But if you looked at the ages of the treated adenomyotic tissue, it was serrated margin. And therefore, we were not happy with that. And we went ahead and did the second setting of the treatment. As you can see, the margins are much better and smoother compared to the first treatment. And patient had an excellent recovery, and a follow-up scan showed further regression in the size and the NPV of the focal adenomyotic tissue. As against that, this patient, which we thought we had done a good study, good treatment, and look at the NPV, it looked good, but look at the margins, they were very, very serrated, very irregular. And as expected, we didn't treat, we said, let's see what exactly happens. We didn't go ahead and do the second treatment, and as expected, the patient came back and had a recurrence, and we had to retreat this patient. When we compared the SSS and transfer score before and after treatment, there was a significant decrease in terms of the SSS, which fell from 28 to 16, and transformed score, which fell from 71 to 40 at the end of 6 months. So, looking at the results, there was a significant reduction in SSS in 74% of the patients overall. When we calculated the NPV, pre and 6 months post-treatment, the mean NPV fell from 139 to 71 at the end of 6 months. And there was a significant reduction in the SSS and NPV percentage of the NPV compared to the volume of the adenomyotic tissue. In terms of the Pearson correlation, it correlated very well with the Pearson correlation. The treated adenomyosis volume went up to 0.644 as the Pearson correlation, and NPV adenomyosis percentage value went to 0.928, which is significant, statistically very, very significant and very satisfactory. And similarly, there was a significant correlation in terms of the reduction in SSS and percentage adenomyosis reduction, as a tissue reduction, comparing volumes of adenomyosis prior to the treatment and to the 6 months post-treatment. And you could see the Pearson correlation came to 0.736, again, which was statistically very, very significant. In terms of the adverse effect, 80% of the patient had no adverse effect whatsoever. Few had the abdominal pain, some back pain. The one patient had the first-degree burn, and this patient had come to us following the surgery and had an extensive scarring at the site of the surgery in preuterine area, and therefore it caused the first-degree skin burn by the heat, obviously, which was absorbed in the scar tissue. Recurrence rate, 7 out of 94% showed recurrence after 6 months. Pregnancy, out of 22 patients who came for the infertility, 3 became pregnant, which is a good figure. So MRgFUS was essentially done for uterine fibroid, but now we are doing it adenomyosis in large number. Dysmenorrhea was the preliminary symptom, followed by menorrhagia and infertility. Similar results what we have seen were obtained by Fukunishi and Tianyang-Fan. They used the percentage decrease of the adenomyosis. Our methodology did not use the percentage difference for analysis. However, conclusion of the study is more comparable and similar. Our study showed a significant reduction of NPV. We used the volumetric assessment of NPV and the adenomyosis volume percentage, that is NPV percentage decrease, and correlated these with the reduction in the symptom severity score. And what did we see? Reduction in score showed a Pearson correlation of 0.644 and 0.928, with NPV and NPV percentage respectively indicating a strong and a very positive linear correlation. So pregnancy and live birth rate in our study was 13.6%. So it can provide a very effective treatment of adenomyosis, is able to achieve a good NPV value that will result in clinically significant reduction in symptoms, reduction in SSS, this is important, and percentage of adenomyosis reduction follows the NPV very closely and linearly, which means that achieving greater NPV will essentially result in significant symptom reduction. And that may be one of the reasons why we got it, because our NPV was appreciably higher. This is safe speech procedure with minimal side effects and same great team which helps me. Thank you for your kind attention.
Another great presentation, thank you. Can you talk about what sedation protocol you use with these patients?
Protocol. Our anesthesiologists, we don't, it's a conscious sedation. Obviously, it's a conscious sedation, and our anesthesiologists, by and large, seem to prefer propofol. That's the standard medicine they prefer.
Okay. And also, can you talk a little bit about any difference in the treatment parameters for treating adenomyosis versus fibroids? We
always use the higher energy to treat the adenomyosis. For the fibroid, we would use it 2,500 to 3,000 joules, while for adenomyosis, we go up to 4,000 joules.
And do you still try to achieve the same temperature, or do you try to achieve a higher temperature?
Honestly, we have tried all kinds of things, but the temperature range for adenomyosis is slightly more than the fibroid. The energy levels are certainly more than fibroid, no question about that. And the spot size also, we increase a little more when we are treating the adenomyosis as compared to the fibroid.
And I thought it was interesting, the slide you showed about the second treatment in that adenomyosis, where it started to respond after the second one versus the first one. Can you hypothesize about why
that was? So, as I told you, looking at the serrated margin, we are learning. Everything is a learning course. Initially, we used to think it's a good NPV, probably going up to 70%, which has been described in the literature, is good enough. But looking at the margin also helps in a very, very big way. As in first case, the first adenomyosis which I showed you had an NPV of around 60–62%, but the margins were very, very serrated, and therefore we were not happy, and we went ahead and did another setting. While in other patient, the NPV was almost 72%. Margins were serrated. There was a discussion in the department, should we do the second? Because the margins are serrated. And they said, no, NPV is more. Let's see what happens. We'll have a close watch. And as expected, patient came back with the symptoms, and we had to retreat. So I think the serrated margin also is one of the criteria to decide, in addition to the NPV, whether you should go ahead and do one more setting. We like to do the nice scraping of the borders of both fibrous and adenomyosis.
Yeah, okay. Thank you. I find sometimes when I treat adenomyosis, I actually do the same spot twice.
Yes.
One right after the other, or maybe a few sonications after, and just changing the permeability a little bit, or changing the vascularity of that section just a little bit, makes it more heat sensitive the second time.
I fully agree.
So
yeah, absolutely.
You can either do it at the same time, bring them back.
Absolutely.
But I think in an adenomyosis, that may be an important technical parameter to look at.
I think MRgFUS is a great modality to treat adenomyosis, because there is nothing else in a symptomatic, uncontrolled adenomyotic pain except removing the uterus, which doesn't help. And so this has come as a big, big boon to adenomyotic patients.
We have one question. Yes.
Just a remarkable volume I think you have there. Is it possible to call back your gynecological colleagues and talk about some of the patients who may be randomized to alcohol embolization versus focused ultrasound? Is that a trial that could be done in your institution?
Sure. We certainly do that. Not that all gynecologists are not our friends. Few of them are our friends. And sure, few of the cases which I showed you, especially the adenomyosis patient, the number of pregnancies which I showed you, the 3 pregnancies, out of that 2 were sent by the gynecologist. And as we will do it, this is a good point I take, and we certainly will try and do that study. I didn't mention that our first patient of the adenomyosis, which was a diffuse adenomyosis, we started doing treatment. And FDA had still not approved the treatment for diffuse. It had just approved it for focal adenomyosis. She was a gynecologist. And she came and insisted on getting this treatment. And when we told her, because we don't want to do it because it's still not FDA approved, she says, I'm ready to take all kind of risks. She gave it in writing, and she went ahead, and trust me, she came back for the retreatment at the end of 5 years. And that too because she got a little pain. And as she was so convinced about this treatment, and we did her MR and we said, you don't really need it. She says, forget it, I don't mind it, give me one more treatment. So that subset of patients do exist.
Okay,
Thanks.
thank you so much. Thank
Thanks.
you.
Yeah.